volume of distribution? Well, it is the volume of fluid, apparently required to contain, the total body amount of drug homogeneously, at a concentration equal to that in plasma. In simple terms, how much amount of body fluid is required to make the concentration of a drug same as in tissue and plasma. Let's take a hypothetical case. A patient has 5 liter of total plasma or blood volume. In this case, if we administer 1 ml or 10 mg of paracetamol, the concentration becomes 2 mg. Now, as per the definition of volume of distribution, it is the ratio between dose by plasma concentration. In this case, it will be 10 divided by 2, which is 5 liter. This means our 10 mg of drug is dissolved in 5 liter of total body fluid, which correlates to the patient's plasma volume. However, this is not the case always, because all drugs do not remain in plasma. Some diffuses rapidly to other organs as well, like liver, kidneys, brain, etc. Hence, here we can consider plasma as first compartment, and rest of the body as second compartment. For ease of understanding, 3 phenomena can occur in this case. First, most of the drug remains in the plasma or first compartment and very few goes to the rest of the body. Second, most of the drug remains in the second compartment and very less in first compartment. Third, 2 compartments can have equal concentration. This rate of drug distribution between 2 compartments depends on 2 main factors: lipid solubility and plasma protein binding. Let's understand this way. Blood vessel consists of lipid bilayer, which means lipid-soluble drug can easily pass through the wall, whereas lipid-insoluble drug cannot. Hence, drug which is highly lipid-soluble tends to distribute rapidly to rest of the body, increasing volume of distribution and vice versa. Second important factor is plasma protein binding. Drug as such has a tendency to cross the membrane easily, but once it is bound to plasma protein, the molecular size of the drug-protein complex increases, hence, cannot pass the membrane and stays in the plasma. This makes the drug long-acting, as the bound drug becomes unavailable to both action and metabolism. The plasma protein binding has a great significance in clinical pharmacokinetics, that can be remembered as 4Ds. Since protein-bound drug stays in plasma, which makes it long-acting. As drug cannot diffuse to second compartment, volume of distribution becomes low. One major drawback of high plasma protein-bound drug is, it is vulnerable to be displaced if encounters another drug with higher plasma protein bindings. For instance, diazepam has 96% plasma protein binding capacity, while warfarin has 99%. If both drugs are given concurrently, warfarin may displace the bound diazepam, as warfarin has greater binding capacity. Lastly, since the molecular size of the drug-protein complex is higher, dialysis of such drugs cannot be done in case of poisoning.